All right, we'll give it one more minute. People are coming in.
That's what they're seeing.
All right,
Well,
Janelle, you want to go first? Yeah.
welcome everyone to the Fireside Chat with Dr. Tom Catena. We are excited for you to be here today. African Mission Healthcare is focused on transforming healthcare throughout Africa. And so today I have the honor of introducing AMH's board chair and has been our co-founder and one of the largest donors for African Mission Healthcare and all of the work that Tom does. So Mark Gerson is going to be our facilitator for this conversation today, and he will introduce our panelists. Mark, I turn it over to you.
Okay, thank you, Janelle, and thank you everybody for coming, particularly after the flight arrangement change from last week to doing it today. So it is my great pleasure and honor to be here with everyone today, and particularly my co-founder at African Mission Healthcare and its CEO, Jon Fielder and Tom Catena. And I think everyone or most people know about Jon and about Tom. So I'll just give a brief description of Tom and his work before we get right into what's going on the ground right now. So Tom, as many people know, graduated from Brown University in 1986 as an All-American football player, went to Duke Medical School, became a Navy flight surgeon, and then decided to devote his life to serving the poor with his medical skills in Africa, and started his career in Kenya, and then went to the Nuba Mountains, where he has been for almost 20 years. And so we'll get into Tom's work in the Nuba Mountains, a little bit of what he's done to date, and most of what he's doing now. And if anyone has any questions or comments, please just put them in the chat. I can see them from here, and I will ask. So, Jon and Tom, welcome to the AMH session where we're going to learn about Tom and the importance of his work and the critical importance of everyone's support.
Thanks, Mark. So thanks everybody for showing up today. I know it's Saturday and you guys have been watching the college football game, so we'll hope to make this enjoyable and informative. Thank you for joining us.
Yeah, I'd rather watch if we were in the 80s and you were playing, but it's not, and you're not. Okay, so all right, so Tom, why don't we just start by just describe a day in the life of Tom Catena in the Nuba Mountains.
Yeah, so well, I guess there is no typical day, but I normally get up around 5:30 in the morning, and I haven't set an alarm for about 20 some years. I just wake up. I don't know why that is, but I can't sleep anyway, so I'm up anyway. So 5:30, get up my wife and baby. We kind of sleep together in the same bed. The last kid is a year and a half old, little baby Vinny, Vincent Moses. So we
You
all
have
get
two
up,
boys now.
two boys. Francis is 8, and Vincent Moses is a year and a half. Both kids are adopted, and they're awesome. Vinny's the cutest kid ever, so he's great. And get him up. He goes outside, does his morning routine. We take off his diaper, he poos and pees, and then we all cheer him on, and he really likes that. Then I head down to the hospital after eating something with my wife, and try to get down there around quarter to 7. By 7 o'clock, I try to get inside the chapel and say morning prayers from about 7 to 7:30. 7:30, we have the morning mass. We have a hospital chaplain who's a Nuba priest who says mass every morning at 7:30. 8 o'clock, that finishes up. Excuse me, we start the ward rounds. And ward rounds go from about 8 till about 1:30. And during that time, we'll do a combined ward round with clinical officers, which are like PAs, like clinical officer interns. We have 3 Nuba doctors with us now. They join us for rounds. We have nurses, midwives. We'll do maternity ward first, then go to female ward, which is a combined medical and surgical ward, over to the men's ward, which is another combined ward, children's ward, ICU. And we're seeing patients during that time that come down from the leprosy and TB ward. The finish rounds are around 1:30, and
How
then we
many
go.
patients will you see in that time, Tom?
We'll get through 300 to 400 in a morning round. So we've got to go fairly quickly to get through everybody. We certainly try to address their issues and see all the new patients, take time with them. The ones that have been there, we try to address any new problems coming up, and make sure we take good care of them. After the ward round, we go to the minor operating room. We'll do all the minor surgery cases, which can be anything from setting a broken bone to draining an abscess to doing an evacuation on a woman with a miscarriage. We often have a C-section or two to do during the course of the morning. From there, we go and read X-rays. From there, once we finish up in the hospital work, I'll head to the clinic, to the outpatient clinic, and I'll get through 50 or so outpatients during that time. Finish up around 6:30, and then I go and read through messages, answer emails, and then get home finally and spend time with the family at night, and then take calls. So anything that happens during the night, we have the clinical officers will take calls for the normal problems. So a kid comes in with malaria or pneumonia or something that they can handle, which is quite a bit, they'll take care of it. They won't call me. But a surgical problem, a problem in labor and delivery, or a problem with a patient that's kind of beyond what they can do, they'll call me and I'll go down and help out and do the operation or whatever needs to be done.
So
So
Tom, when you say do the operation, that's really interesting because you're of course trained as a family medicine doctor, but early in your career you realized that there are an enormous number of people in Africa who need surgery, and if you don't perform that surgery, nobody will. So you got trained in Africa in surgery. So what kinds of surgeries will you do on a typical day in Nuba?
right. So when I first arrived in Kenya, January 17th, 2000. So it's been 25, almost 26 years that I've worked in Africa. When I was there, I quickly realized that to work in Africa, you've got to do some surgical work. And how much you do depends on how much you want to learn. But I was fortunate enough to kind of be apprenticed to both missionary doctors and Kenyan surgeons who were willing to teach me surgery. So I did a ton of surgery during my time in Kenya. I did as much of, or actually more than an American trained general surgery resident would do during his time of training. So my what I learned under this kind of apprenticeship was how to do surgery in that context. So, a typical day, we start off usually we start with a C-section, elective C-section. Then we'll take care of the children. So we'll do a kid that's got maybe hydrocephalus, which is a very common problem there. The child has too much water in the brain, and we do what's called a ventricular peritoneal shunt. So it's an operation on the baby's brain to drain that fluid from the brain down into his abdomen. And if we have another pediatric case, maybe a peds hernia, maybe it's a child with a Wilms tumor, which is also common, which is a tumor of the kidney. Then we'll start doing the adult cases, and we'll do the usual stuff: hernias, hydroceles, hysterectomies on women, amputations are very common, laparotomies for all kinds of abdominal tumors or intestinal obstructions. We have a trauma case, a gunshot or a stab wound to the abdomen. So it's really a tremendous variety of cases that we'll get through in a single day,
Yeah,
including orthopedic.
this is astonishing from an American or even a Western perspective, where surgeons are, I was going to say typically, but always specialized. And last night, Tom, you were over for Shabbat dinner, and we were talking with a surgeon who does upper extremities, which is and so it sounds like you do every kind of surgery because you're the only surgeon in Nuba for 3 million people. So if it's not you, it's not happening.
Right, that's our setup. So we're the only surgical hospital for 3 million people. And not only those 3 million that are in Nuba Mountains, but we do the surgical care for South Sudanese live in the northern part of South Sudan. We have people coming from the north. I mean, there's terrible civil war going on. We had a patient come from Darfur, which is way far away from us, and she had a cancer of the cervix. She was seen at a hospital in Darfur. They couldn't handle her problem. So they referred her to Juba in South Sudan. Juba is the capital city of South Sudan. It's very far from us. It's a long drive and a long flight to get there. Anyway, in Juba, they couldn't handle her handle her problem either. So they referred from Juba to our hospital in the Nuba Mountains. And she made her way up to us. And we gave her chemotherapy for 1 or 2 cycles, and did an operation and then more chemo afterwards. And she's doing quite well. I saw her just before I came out.
So, okay, so Tom, so you're doing all kinds of surgeries and as well as all kinds of medical care, and we already have some really interesting questions in the chat, and this one I think Jon can help with as well. Let's talk about the delivery of drugs and equipment. So Tom, you and John have done the really, and I use this word carefully, awesome work of building a first-class hospital in the poorest place in the world. And as a first-class hospital, you need drugs, you need equipment, you need all kinds of other stuff. In an environment where it's very difficult to get anything to. So, how do you do procurement of drugs, equipment, and anything else you need in the hospital?
So the logistics are the biggest challenge. I mean, we have tons of challenges and problems. Logistics is certainly in our top five of difficulties. So for us to get anything up to us, we have no access to the north to Khartoum. I mean, Khartoum's been totally trashed now, but even before, when it was functional, we couldn't access it because of the civil war. So all of our everything we have to get from Nairobi, which is 2 countries away, or in Juba in South Sudan. And African Mission Healthcare is our main partner that provides that logistical support. So we'll make our order for the year. We've got to order everything we need. We make an order for about a year and a half, just to give a bit of a buffer in case things run out early. So we order everything for about a year and a half. We send that huge order to the AMH's office in Nairobi. They do all the heavy lifting of the procurement, buy all the items, compare prices, try to get the cheapest price on all the goods. They'll do the booking of the trucks, and transport services, put those things in the trucks, and then the trucks start the long journey from Kenya to Uganda to South Sudan, all the way through South Sudan, up to the refugee camp in the northern part of South Sudan, and from there it crosses the border into Nuba Mountains and a long trip back up to us.
Yeah, and the difficulty I know is that for several months of the year, it's a rainy season, nothing and nobody can go in and out. So I mean the creativity that John and his colleagues at AMH have done. I remember John at one point there was some issue with transport, so you said no problem, we'll just send stuff down the Nile. Um,
There was a time, and we did have to rely upon a partner organization to help us get some of the supplies down a tributary of the Nile, and then they got picked up by another truck, and then got trucked to the refugee camp that Tom talked about. Sometimes there's cold chain items. Of course, they can't be trucked across, taking weeks to go across South Sudan, which is extremely hot. So we have to fly those items. Sometimes there's emergencies, like there was cholera outbreak this year, and so we had to get some emergency supplies up there more
and
quickly.
that was outside of the 18-month procurement cycle.
That's right. So sometimes they run short of things, or there's an emergency, and so we have to step in with these kind of episodic orders.
Okay, another very good question, which gets to a really important dynamic is there's a question about medical staff training. So how much medical staff can you train? And I think, Tom, one of the exciting things that I've seen in the previous few years, which is really culminating now, is just how effective donor dollars can be, because you've constructed the infrastructure to enable the kinds of training which results in patient care that'll just blossom commensurate with the amount that can be provided. So there's a question here about medical staff training. So let's talk about medical staff training.
Right. So we first opened in 2008. We got there March 2008, and the initial medical staff, where we had 8 expatriates from Kenya and Uganda. We have 15 local staff, 15 Nuba staff. Of the 15, the one with the highest education level had finished 8th grade. There was not a single high school graduate in all the SPLA-controlled territory of Nuba Mountains. So from the very beginning, we started sending people out for training. Over the years, we sent probably 90 staff out for training. We've trained medical doctors, nurses, midwives, clinical officers, anesthetists. I trained an eye surgeon. What else? Lab technicians, pharmacists, operating room technicians. We've trained everybody you would need to run a hospital. And we realized that we're sending all these people out, and we could be a training place ourselves. So we had the idea many years ago. Then finally, we started the training school about 3.5 years ago. We just graduated our first class of clinical officers.
How many
So
people are in the class?
19. So 19 clinical officers. If a clinical officer is like a PA, for those not familiar with that term. So 19 clinical officers just graduated in June of this year. They're all doing their internship with us. So a 3-year training course, then a year internship, And these will be the main health providers at these 19 clinics that we run.
Now,
in all
Tom,
the
what kind of medical services can a clinical officer, once the 3-year internship is completed, what can they do?
These guys are pretty well trained. They can do, I mean, they would be on par with a medical officer, so a medical doctor who's a medical school internship for probably everything except maybe able to do C-sections. Because for the most part, they can treat anything that comes into the outpatient clinic. Most of the problems that come in, the malarias, the pneumonias, the TBs, HIV, they can handle those problems. They'll be familiar with the diagnosis and treatment of all those issues, problems, and then they have to refer, surgical cases, obstetrical cases that are higher level. Anybody who's got a more serious medical problem, so a really bad heart failure, a cancer, a bad diabetic, they have to refer out. But a diabetic that's on oral drugs, they can take care of that. Hypertension, heart failure patient that's on treatment, they can handle that. So most problems they can handle, and that's kind of the clinical officers kind of form the cornerstone of healthcare, not only in Sudan but in most of East Africa.
So and so you have 19 being trained now, and that's a 3-year course. And I believe that that for 3 years the entire expense is $7,500, not a year, but for the whole thing. Is that right?
It's about 7,500 per student for the whole course, right?
Right. And that person will be able to treat, Jon, you would know how many people over the course of his career, approximately?
Yeah, I mean, we generally estimate about 80,000 patient visits.
80,000?
80,000 patient visits. That's right. They'll see. And I saw also, Mark, that there was a follow-up question about training from one of the audience members about training Nuba staff to do surgery. Tom, do you want to talk about that? Because obviously that's a much higher level of service.
Yep.
Sure. Yeah, sure. So that's obviously very, very important to us. For me to come out, for this visit, we had 4 doctors covering, and 2 were surgeons. So when I go back, unfortunately, they're all going to leave. So we need trained Nuba surgeons to take over when I'm either dead or even just for me to take a break. So right now we have 3 Nuba doctors that are with us, and we have several more that are in training in Juba in medical school. They'll be coming up. And the goal is to take some of them and get them sent out for specialty training in surgery. We have a surgical training program already that's it's waiting for them to come. It's in Kenya. It's a mission doctor named Bill Rhodes, who's very familiar to African Mission Healthcare. So Bill's a general surgeon and he's a plastic surgeon. It's Bill and his family are all there. His kids are all surgeons, so they're ready and willing to take our guys when they're ready for training. So hopefully, we're planning for next January. We want to get at least 1, if not 2, of our medical doctors sent there to be trained as surgeons. It'll take 5 years, but we need to get things going. So we get that started. So we very much in our plans to get general surgeons training, and then on top of that, we'll get the other cadre training, whether it's a pediatrician or whatever. A gynecologist, not right now. We're able to do for the obstetrics and gynecology that we need at our hospital. We're already able to do the vast majority of that. The real subspecialty things you need, we're not able to do. So the most important person to train right now is a surgeon, and we probably need 2, just so the workload is a bit evened out.
Okay, so many good questions. I'm going to dispense with the ones I had and just go with these. So Jon, this one's for you. What would you say is the order of operations to bring healthcare and build health systems in places where there currently is none? Because Jon, I mean, you've overseen the work of dozens of hospital partners in South Africa, so I'm going to give this to you. So what would you say is the order of operations to bring healthcare and build health systems in places where there currently is none? Can your strategy in Nuba be replicated elsewhere? How can the next generation of American physicians or MPHs contribute to this work?
Well, certainly I'd love for Tom to weigh in.
Yeah.
I think, look, if you were starting from an absolute blank slate, I mean, you'd start with some of the basic sort of public health interventions. I mean, things like immunizations, for example, and clean water. In a lot of places, and certainly there are holes in those services in Nuba, but in a lot of places in Africa, those things do exist. Again, there is some inconsistency, but a lot of those systems do exist. where we tend to focus both as AMH and then with Tom's work is now building kind of the next tier there, which is, what we would think of as, bread and butter medicine. Somebody comes in with appendicitis, somebody has pneumonia, a child falls out of a tree and breaks their arm. And in order to take care of those kinds of things, you need strong hospitals. And that's what we're really focused on, is trying to make hospitals stronger, trying to help hospitals like Tom's to be stronger, and then to push that quality out, as Tom talked about training, and get more of those trained midwives, trained clinical officers out to these rural clinics, of which Tom's hospital oversees 19. Tom, I don't know if you have anything to say to that.
Yeah, I just would probably add, John, that just to put you in the picture out in Nuba Mountains, I obviously saw that picture on the ATV when I was coming out, but this area is completely undeveloped. So there are no roads, there's no transportation, there's no bus, no taxis, no Uber, nothing. So
Well, and Tom, last night you were saying there's no running water, no electricity,
right. So in the hospital we
no
have those
toilets.
things. We have
Yeah.
solar power and we have a solar pump that by gravity feed. We have taps and we have running water there, but we're it. Like nobody in the villages and outside, nobody has running water, nobody has electricity, nobody has a toilet or even a latrine. So this is kind of the basic setup. And if these villages are very, very remote. We're remote. They're even more remote. So the idea is we have to take healthcare closer to the people, improve the access. So you do that, everything's got to go in tandem. You got to have the clinics. Those clinics have to be outfitted with the right equipment and proper medicines, and you got to staff them with trained people. And the most appropriate training, we don't have enough. You can never train enough doctors for all these clinics, but a clinical officer and a midwife, this is a very appropriate training level for those clinics. Just as an aside, for surgery, I was talking with somebody else earlier this morning about surgical care. And like I said before, when I first got to Kenya, I realized what a huge need there was to know some surgery and do surgery. And um, John knows the numbers on this, but there's a huge unmet need for surgical care in Africa. And a lot of the big donors, Gates Foundation and Global Fund, they focus on kind of big picture issues. So how do you take care of a huge swath of people with vaccines, with medicines, this kind of thing? And that's great. That's necessary. But because of that, there's a big void there's a big deficit of surgical care, not only in Africa in general, especially in the mountains. And John, would you want to add something to that? I know you got numbers and you're very much involved in that. If you have something to add.
Well, I mean, across the continent, there's several hundred million people who need surgery now. I mean, for some kind of untreated surgical condition. And in some countries, out of the people who need surgery, maybe a few percent of them are getting it. And things are even worse for pediatric surgery, because that often requires some special training. And again, to provide, and probably somewhere on the order of 20% of preventable deaths in Africa are somehow surgical related. So if you look where Tom is, there are some accidents on the road, but of course there's war trauma, and there's obstructed labor and C-sections, and there's blocked intestines. There's all kinds of things like that. And when I say a strong hospital, you have to have that strong system. Meaning, if you look at surgery, if you don't have power and backup power, if you don't have clean water, yes, you've got Tom the surgeon, but you need anesthetists. We train scrub techs, meaning the operating room techs who pass the instruments to Tom and take care of all the instruments. You need the anesthesia machine. You need the light. In other words, you need a system. And to build these kind of systems, whether it's for surgery or some other kind of care at the hospital, really requires a lot of time and attention to those details.
Which actually gets to another interesting question in the chat here. Tom, how do you use your engineering background in your everyday life? Now, John talks about the need for a system. Engineering is part of a system, and John, who's spent his career not only running AMH but as an infectious disease doctor in Africa, has often said that the engineer is as important as the doctor in a hospital. And Tom, you're kind of both.
Yeah, well, thank God we have a real engineer with us now who's an absolute genius, Chris Lowe, who's from Washington State. And I mean, he's bailed us out of so many problems. You know, my before Chris came, my biggest anxiety, it was, I mean, patient care is very, you know, caused a lot of anxiety. My biggest problem was that the physical plant could not function. So you can have all the medicines, all the tools, you can be the best doctor, but you can't do anything if you don't have power and water and a functional system. Or, you know, we were always like one nut or one bolt short of just shutting down. You know,
Wow.
it was a miracle we kept things going. And I did use some of my engineering background, just systematic way of thinking to kind of solve some of these problems. Um, you know, I mean, the morning would start off with, before I even got there, somebody come to my room and say, "Hey, there's no water today, or the power's out, or there's a fire somewhere." I mean, every day was something new. And before even starting to see patients, I had to go and kind of sort those issues out. And, you know, it was really very distracting. Uh, but it pressed on me that what you need to run a hospital and these systems is you need a team of people. If you're trying to do everything yourself, you'll never make it. I mean, it was a miracle we made it through, but it's so much better now that we have a real guy there who can really fix anything. I mean, he saved us tens of thousands of dollars by just fixing lab equipment, just one thing alone, let alone everything else he does. But just things broken in the lab that we have to fly an expert out from Nairobi. He would come and fix it and say, I don't have the proper thing, go back. Chris goes and fixes this stuff. And then not only saving money, but that machine will be shut down. It could be 2 months. We can't do those tests. He comes and fixes it. He figures out what's wrong with it and fixes it. So a tremendous help to us.
Yeah. So let's talk about the budget of the hospital. So the budget of the hospital is around what, John? $3 million a year?
Yes, it'll be in this coming year in 2026. It'll probably get closer to 3.5.
Okay, so 3.5 million, and for that, Tom is seeing a couple 100,000 outpatients, something like 7,000 inpatients, thousands of surgeries, plus leprosy care, TB, HIV, births, and training.
Yeah, if I can interject, Mark, that's so that budget 3.5 million, it was 3 million last year. So that includes absolutely everything from every tablet we have there to paying all the staff to running a 485 bed referral hospital to running 19 clinics, to running a clinical school, training clinical officers and midwives, all the construction going up. That includes food that we need to treat all the inpatients. So we have, you know, 9,000 inpatients. So we're able to get enough, we have to buy enough food to feed 9,000 inpatients, plus what's called a co-patient. They always have to have a patient with them that helps prepare the food and do some of the caretaking with them. So for that amount, our total numbers is 300,000 patients are seen. We do 9,000 admissions. We ourselves, major operations, we did 1,200 major, 2,000 minor operations. God knows how many cataracts our eye guy did. He probably did 700 cataract surgeries. We have a dental clinic now. We have a building going up that's going to be a physical therapy department. We sent two guys for training in how to make leg prostheses for amputees. So we're going to have our own workshop making prosthetic limbs for leg amputees. It'll be the only place probably in all of Sudan
Wow.
that's doing that. We have an isolation ward that just went up to treat these cholera patients. So it's that money that you're talking about includes all this stuff from A to Z. It covers everything.
Yeah, I mean, I was incredible. It's staggering what you're able to accomplish per dollar. I mean, you run the hospital on $7,500 a day. So, so when people think and we think about what we would each person wants to give, what we can encourage others to give. I mean, just someone's birthday, anniversary, whatever the special day is, $700 keeps Tom's hospital, everything we're talking about, going for a full day. Now there are several questions here, Tom, which congregate around one theme, which of course is something that everyone who's blessed to know you asks. And I'll just read one of these questions, but several are appropriately similar. Let's talk about your faith, your Catholic faith. You're a Catholic missionary doctor. How has serving in Africa affected your own lived experience of health, faith, and community?
Right. So, I mean, the reason I'm there now is I'm there as a Catholic lay missionary. You know, in the Catholic Church, you've got lay people, which is people like me, and you've got consecrated people, which would be the priests and the sisters and the brothers. So I always wanted to be a missionary. I had that kind of that call from my days in college, and actually went into medicine to answer that call of mission work. And for sure, I think without that faith underpinning, I would have left a long time ago.
You never
We
would
had
have gone.
Sorry.
You wouldn't have gone to begin with.
I wouldn't have gone. You're right. I would have gone for a year. I would have
Right.
said, okay, I've had enough of this. Yeah, my original idea was to go kind of get it out of my system and then come back. And then when I was there, I realized the need and just work with a lot of incredible missionaries over the years that inspired me to keep going. I saw their faith and their commitment. I thought, man, I want to be like these guys. And I kind of kept at it. But without that daily, for me, that daily prayer life, daily, the chance to go to mass every morning and to kind of put that front and center, I could not have, I would have left a long time ago. The work is too difficult. It's too psychologically difficult to stick it out.
And even when things got very dangerous, you've been saying that your faith is what kept you to stay.
Right. I mean, I was there, you know, the way I look at things very simply. I'm there as a missionary. And what does that mean? Well, to me, it means showing the love of Christ to other people. It's not something complicated. And to do that, you've got to be a witness of what Christ was like and what his apostles were like. So what kind of it's not a very good witness if people are watching us and they see us and okay, danger comes, difficulties come, and the missionaries all turn tail and take off. That doesn't show you've got a very strong God, a very strong faith. So myself and the two Kamboni sisters that were there and the parish priest who's from Uganda, we all decided that we were going to stay no matter what happened, and we kind of supported each other in that.
Okay, so there are several questions congregating around another area, which is the stability of the region, and the current conflict and how it's impacting the hospital, the region, and your work.
Right. So, you know, Sudan, as I think everybody knows, is a bit of a mess, and it's been in the news the past couple of weeks. So, 70 years as a country, so it'll celebrate, if you can call it a celebration, 70 years as an independent nation, January 1st, 2026. Out of 70 years, it's been in civil war for about 56 of those years. And the most recent civil war started April 2023. And initially, it was more kind of in the north of Sudan. It was kind of two warlords that had deposed the transitional government and then they started fighting each other. They were in government, they were running the government themselves, then they turned to each other and started going at it. Where I live, our region is controlled by the SPLA North, and they control the entire area. And they've been fighting the government for generations. But initially, they were kind of out of this fight between the Hemeti, who's in charge of the RSF, and Burhan, who's in charge of the Sudan Army. More recently, they joined forces with the RSF. So now the SPLA North, which controls our area, has kind of joined the fight. So it's not very stable. We had a lot of wounded, a lot of fighting in the dry season, the last dry season, which ended around June. A rainy season was fairly quiet in terms of fighting in our region, but very heavy in other parts of Sudan. Now, when I go back next week, it's dry season again. So we expect more conflict and more fighting, probably closer to us. Who knows what's going to happen? But it's not stable now.
Um, so it might not be stable now, but there's a question in the chat too about hope, and this actually came up last night at the Shabbat dinner that we had with you, and there seems to be more hope than ever given for your work and what you're doing, given the capacities, capabilities, and infrastructure that you with AMH have built. So let's talk about, we talked somewhat about the numbers of people that are being trained. Let's talk about that with relation to people being trained for maternal care specifically, as well as the clinics that you're building, and which have as a part of them, a crucial part of them, the BMOG centers, and of course, explain what that is.
Right. So, you know, hope for us, hope is very much a Christian virtue. We're people of hope. That no matter how awful things can be, we always know that God is there. And as I found out last night, Mark, you told me That's a Jewish virtue also. And
Yeah, that's the Israeli national anthem. Hatikva means the hope.
right, so we probably got that from you guys. So, I think without that you can't survive there. And the way we translate that, how do you take that hope and translate it? So for us, no matter what's going on around us, we're not gonna close up shop. We're gonna keep going. We're gonna continue on with what we're doing, and not only that, but we're determined to expand the services we offer, to keep improving what we're doing. So, medicine's like many things in life. You can always improve, and we want to keep getting better. We want to keep providing better healthcare. We want to keep training Nuba health personnel. We're not going to stop and say, well, there's fighting going on. We're stopping the training schools. We're going to start another intake this coming July. So we're going to keep going. And the upgrade includes this BMOC. So we have 19 clinics. A BMOC is one of these NGO terms that stands for Basic Emergency Obstetrics and Neonatal Care Center. So the idea is you have a basic clinic that's doing, seeing out patients, treating malarias and pneumonias and, hypertension and diabetes, usual stuff they see, and they're doing very well at that. So we want to make these places into birthing centers with staffed by hopefully 2 trained midwives. We'll graduate 29 in June. We want to staff these clinics with trained midwives. And a BMOC is just going to be an upgraded clinic. So it's going to, most people, 90% of people deliver at home with disastrous results. Nuba Mountains, we have data from South Sudan, some data from Nuba Mountains that puts us at the world's highest maternal mortality rate, and certainly the world's highest neonatal mortality rate. In South Sudan, it's like 1,273 deaths per 100,000. In the US, it's like 5 per 100,000. We're way off the charts. We are either the same or worse than South Sudan. So we want to improve that. How do you improve it? You upgrade the clinics so they can have a trained midwife. You provide the tools necessary to do that. You have a good antenatal clinic to screen people that are at risk, send them to the hospital. Those they can deliver, they have a skilled birth attendant, a trained midwife doing that delivery. So they can give IV antibiotics, they can give medicines to augment labor or to improve the labor if they're having difficulty. They can take care of a woman who's bleeding after birth. They can treat a miscarriage. So a woman who's early in the pregnancy, she miscarries. They often have heavy bleeding. There are a lot of deaths from that. They can treat that miscarriage. We're training them how to do that now. They can do what's called a vacuum delivery. And they can do all these things in addition to what they're doing normally in the clinic. So it's a really big upgrade to what we're already doing at the clinic.
So it seems to me, Tom, that no matter what happens politically, militarily, you're building, and in the future, and the not so distant future, if we can provide you with the financial resources that you need, the care for the people in Nuba will be amplified beyond anything we could have imagined even 10 years ago.
Right. So our goal is to become we've already changed our name from the Mother of Mercy Hospital to Mother of Mercy Referral and Teaching Hospital.
Oh,
And we want to keep that. So our official name is actually Mother of Mercy Referral and Teaching Hospital. That's going on our signs and everything else. And we want to be the referral hospital for not only Nuba Mountains, but for Greater Sudan. And now is the time to expand it a bit because the health infrastructure in the north, because the civil war, has been trashed. Our facilities are still intact, and we want to become a referral hospital for the entire region. So to do that, you've got to have more than one surgeon. You need several surgeons. You need specialists. We've got to up our game. So we're slowly building that infrastructure to do that.
okay.
Mark.
The next, yeah, John, what were you saying?
Yes, I just wanted to follow up because there was an interesting question in the chat that dovetails with what Tom was talking about with maternal health centers. And there's actually a member of the audience who's from Nuba and is from Farish, and I've been to Farish. And the question from this audience member was, what happens if somebody needs to get to the hospital in an emergency from a place like that? And it happened when I was in Farish, and this happens a lot when I either go to Nuba or some other places, go to rural clinics. Almost every time there is an emergency when we visit. So like in this case, there was a man who had pretty bad malaria, and we had some malaria medicines, but he couldn't keep them down. So he was vomiting them, and he was sick enough he needed to come to the hospital. So of course we put him into we were in an ambulance vehicle that That's how we got there. So we put him into the back and brought him with us. And it must have been an absolutely horrible trip for him because, the roads were so difficult and he had a lot of nausea. But Tom, do you want to speak about the systems that are being put in place for referrals, and the ambulance that exists?
Yeah, it's a good question. So, I mean, Ferris isn't even that far from us. You can walk, it takes about a 3 hour walk. So it's in our local area. It's the same tribe that we have in Udell. So yeah, one huge problem is access to care. So that's one reason why we want to get the clinics out there. The second thing is if they need to get to the hospital, how do they get there? So um, one thing we've done, now we have an ambulance that we've posted in a place called Hebon, which is maybe an hour and a half from the hospital, and at another couple clinics that are south. So Hebon is a bit north of us. Other clinics south of us, we posted a couple what I call tuk-tuks. They're little three-wheel drive things. There's a small space in the back where you can put a patient. So what we'd like to do eventually is outfit most all of our clinics with these smaller tuk-tuks and make them like mini ambulances. So it's kind of spokes in a hub. We're going to be the hub. The clinics are spokes, and those spokes have a small vehicle. They can maybe take them either all the way to the hospital. They can make it all the way, part of the way, and then another place between those remote clinics and us is another ambulance, a real vehicle, like a Land Cruiser. That's a real ambulance, and the tuk-tuks could at least make it part way. Then they hand it over to the ambulance, and ambulance can take the person in. But transportation is a huge problem, and look, to do that, it sounds okay. Just go and buy the tuk-tuks and buy the ambulances, but it's complicated. You got to the equipment. Tuk-tuks are not that expensive, but we've got to get them out there. We've got to get fuel for them. We have to get people to drive them. We have to make sure people are not using them for joyrides and for their own purposes. So it's something that we're working on, and we want to keep thinking about it and keeping it. A lot of these things, we have the idea, and it takes 2 or 3 or 4 or 5 years for that idea to come to fruition, just because all the different complications and problems that are in. But we're working on it, and we hope that comes out in the next few years.
The next is not a question, but it's a comment in the chat, which is so nice. I just want to read it. Dr. Tom, thank you so much for all you do. I'm an OB/GYN currently in Texas, but I've worked in both Kenya and Malawi. I saw you a few years ago waiting for a flight at the Addis airport and wanted to say hi and introduce myself, but I was too shy. And I've wished ever since that I have introduced myself and thanked you for your mission and your faith. You continue to be a role model and an inspiration for me. Well, you're certainly that for all of us, but I would say if anyone sees Tom in the airport, don't be shy. Say hello.
Please say hello.
Okay, so there are a couple questions here. One about cataract surgery. So the question is there a possibility of doing cataract surgery outreach in Darfur? So we can talk about the cataract. First, tell us what a cataract is. I'm not even sure myself. What
So
is a
cataract
cataract?
is
Yeah,
a cataract.
and then talk about what it is, what do you do now, and how are you going to expand that?
Cataract is basically a clouding of the lens in the eye. So it's due to many things. One is salt water, which obviously is not a problem for us, but a prolonged exposure to sunlight is one of the big risk factors, and age. So we've got sunlight in spades there. So a lot of our population have cataracts, and they're,
Does it
some are,
blind you if you have
it
it?
blinds you, right? It's kind of looking through an opaque window or looking through stained glass. You can kind of make things out initially. So at first it's very blurry. At first you start with night, difficulty seeing at night, and then you start getting really blurry vision. Then you have total blindness. And it's something which is 100% treatable. And we have people in their 50s and 60s with really dense cataracts. They can't see anything.
How long would they have had them for?
I mean, they develop over several years. So it's something you start when you're younger, and it just kind of develop it over time. We have a clinical officer, like a physician assistant, who's trained in cataract surgery. We sent him to clinical officer school, came back. We sent him to Tanzania. He did a 2-year course in how to do eye surgery, and he is the eye surgeon for all the Nuba Mountains, and now for a good chunk of Sudan. I saw Jim Guzak's name come up. So Jim's an eye surgeon in Washington. Hi to Jim, and Jim's coming out next month. Jim has come out several times to help this guy Caesar, and has been a tremendous help. I think the issue with doing it in Darfur right now is probably not possible because of the civil war. I mean, eventually, if relations were better and we're able to do it, we'd love to do something like that, where we take our guy Caesar, and we send him out there. This is the idea. We want to get our guys trained up let them be missionaries. Let them go out to places that are even more in more difficult situations, to go to places and use their skills to help that population.
Um, okay, question about anesthesia care and supply availability. Good question. I know that's come up a lot.
So for anesthesia, we have three trained nurse anesthetists, and we're in the process of training two more. They were all trained. Two of the guys were trained as nurses initially. One guy has finished 8th grade, and he was trained on the job. He did a 3-month course at Kijabe, which is in Kenya, where Jon is right now. Other two guys did nursing school, came back, sent them to Kijabe, a 1.5-year course. They're all trained as nurse anesthetists, and they're fantastic. They're very well trained. Kajabi does a great job in training them, and it's a great way for mission hospitals to cooperate and work together. We need more. I mean, they're it for Nuba Mountains. We need more trained. So we're in the process now of getting more trained. Our anesthesia setup, if they're anesthesiologists or anesthetists out there, it's very, very simple. We use something called an OMV, which is an Oxford miniature ventilator. It's a tiny little device. It's about the size of an espresso machine, and that takes halothane. And just with that simple device and a set of bellows, so that we don't have a ventilator, we don't have a machine that breathes for the patient. So the anesthetist has to breathe for the patient by squeezing a bellows. Looks like an accordion. By squeezing that accordion, and that pushes air into the lungs. That air is infiltrated with halothane, which is a gas which puts the person to sleep and anesthetizes them. So very simple device. And they anesthetize everybody from 3-pound babies who have congenital problems with their intestines to old people that have intestinal obstructions. They do the full gamut with those very simple devices.
Okay, a question about your U.S. trip in the last few weeks and travel. I would say it's a miracle, maybe an actual miracle, that you haven't had any flight delays after the one, which was actually a mechanical problem that caused this webinar to be postponed. But you haven't. Your travel's been fine in the U.S.
Yeah, I consider it an absolute miracle. Before I came out, I saw about this government shutdown and all flight cancellations. I'm like, we've been planning this trip for, I don't know, how long has it been, Jon? It's been a year, more than a year. It
Yeah.
seems like forever. Making all the plans, all the venues have been set. A lot of time and effort and resources have gone into that. And I thought it's going to be a disaster if I get out there and we got to start canceling flights and we can't show up. So I think it's an absolute miracle that all these trips have gone off. This is actually my last day of this is my last event. Well, I got one with you tonight, Mark, and that's it. And I can
Yeah.
walk to your place, so I don't have to take a flight to your apartment. We're
Yeah.
pretty much done. So thanks be to God, we've managed to pull it off with
Yeah,
God's.
and you've been in New York, Miami, Portland, South Bend, Austin, San Francisco. Where else? North Carolina.
St. Louis,
North Carolina,
North and South Carolina, Connecticut,
Nashville. Yeah.
San Francisco, Hillsborough, California.
Yeah, Florida, Nashville. Yeah, it's been a great trip. Okay, here's a good question that for both Jon and Tom. How does African Mission Healthcare work to partner with Tom along with Sudan Relief Fund and CMMB, Catholic Medical Mission Board?
Mhm. Why don't you answer that, Jon?
Sure. So the three organizations that Mark just listed are the three main sponsoring organizations of Tom's Hospital. There are other partners as well who funnel their giving. It would either come through Catholic Medical Mission Board or through us. So AMH is the largest financial sponsor, and we do pretty much all the procurement except for the fuel, which CMMB does, and then we do a lot of the logistics. SRF also works with Samaritan's Purse to help us with the logistics in some of the South Sudan side. We have seats on the board.
More
We
the
sit on the
hospital.
board with the representative of the church, and then there are also representatives from two Catholic congregations that send staff to work at the hospital from Uganda and elsewhere. And going back to the question before about how can the model be replicated, actually the same three partners support a hospital in Western South Sudan. that's also doing really great work. But we kind of took some of what we did in Nuba in terms of hospital processes and board processes and transfer them to work with that hospital, and that's helped strengthen that hospital as well. Tom, do you want to add anything?
No, I think what I will add is that, just as an aside, we almost had to close up shop end of 2017 for a number of reasons. We had some institutional donors, some pretty large institutional donors that were supporting the hospital and pretty much covering everything, and they dropped us uh, very abruptly in 2017. And these three organizations um, came to the rescue and bailed us out and have been faithful partners ever since. So without African Mission Healthcare and CMB and Sudan Relief Fund, we would have closed up shop 7 years ago, and the place would have been vacant now, collecting dust. So I'm very, very appreciative of the work that all these organizations do. We are 99+% dependent on individual donors to provide that care. So thank you to everybody out there.
No, I mean, Tom, thank you. Thank you for allowing us to direct our financial resources to such incredibly effective and efficient ends. The ROI, the return on investment that you provide, is unlike anything that we've ever seen in business, investing, or philanthropy. So thanks entirely go to you. Here's a very good question. What advice does Tom, or I'll add Jon, what advice do Tom and Jon have for young undergrads, or I'll add medical students interested in going into medical missions?
Well, I'd say first off is of course a discerning process where that's kind of between you and God. There are many ways to serve. I think it sounds like you have a heart for mission. So there are many ways to do that. And I think a pretty long process of discernment. Take your time, spend time with God, and just see what you think is the best fit. And then if you feel called to it, I would not pick a field that you think. I wouldn't pick a field only because you think it's best for missions. I would pick a field in medicine that you like. You got to think about, if you want to do missions, the missions could be a year, 2 years, 10 years. It could be 25 years. It could be going for a month, a year to help out somewhere. So pick a field that you can see yourself doing 30 years down the road. So I finished medical school 33 years ago. And you got to think about what's going to get me up in 33 years. What's going to get me up out of bed at 5:30 and go into work that day? What's going to get me up during the night to go in and see a patient? Do I want to see, which kind of patients do I want to see? So don't, try to think of that when you're going through that decision. And then when you finish all of your obligations, you finish your training, I would do a kind of a test case first. I would go somewhere, say, look, I'm going to commit myself to a month, 2 months, go somewhere for a couple of months, see what it's like, see if it's an environment you like, see if you think you're putting your skills to use. I'd probably do a softer landing at first. I would not kind of step into Nuba Mountains to start with. I might start with a place that's maybe not in civil war, Sudan, Kenya, Uganda, Tanzania. Well, Tanzania is in civil war now again, but Tanzania, maybe if they're stop fighting now. Kenya, Uganda, a place that's a bit more conducive to that. And then, yeah, just go with what you think is best.
Yeah, I see. Jon, not a question, but a comment in the chat. Nice to see Dr. Fielder, my mentor in healthcare and HIV/AIDS while at Kajabi. So,
That's nice. That's nice to hear. And I would follow on what Tom said. I agree with everything that Tom said, and say that you've heard us talk about how long it takes to get things done. And it's just years of, Tom started with, a few expatriates and 15 local staff, none of whom had even a high school education, to now, if we include the outreach clinics, there's 370 staff. And we have over 100 or either have been formally trained or in training. And, that's an 18-year time course. And I'd say that's remarkable. It's a miracle. Some things can, that might seem simple, might take a year to happen. But there's another way. If you don't end up being involved full time in the field, is to develop, a strong relationship with a place, get to know the people. I worked in Malawi, and we had some people come from UCLA Medical School, and they were just great. I mean, they're great people, very smart. We were predominantly an HIV clinic, and some really leaders in the HIV field. And the thing about them is they would come every year, and they knew everybody. And so when they would come, you didn't have to kind of explain everything to them every time when they came. And they, the staff would know them, and they would know the staff, and they would know what's possible in Malawi and what's not possible. And that kind of recurring relationship is so valuable.
Yeah, I'd say, Janelle, if you could put the donation information again in the chat. Oh, there we go. Very good. So, and yes, and if someone wants to do by check so they don't pay credit card or bank fees, that's great too. You can reach out to anyone at African Mission Healthcare, or Janelle can put that in the chat too, and we could certainly instruct along that. Here's not a question, but a comment. I cannot let this opportunity go without touching in to express my deepest gratitude to God for the work that He is doing through you, Tom and Jon. I lift you up in my prayers often, and often share your incredible story with others whenever I'm able. May God continue to bless your breath, your steps, your prayers, your heartbeats, your thoughts, your challenges, and every effort you make to bless the beloved children in Africa with health and hope. May God's will be always done in your midst.
Thank you.
Beautiful. Thank you. Okay, so I think with that we can probably with that we can conclude. That summarizes so beautifully and completely. And I think I'll just say in conclusion, I just want to express my my wife Erica's just deepest gratitude to Tom and to Jon for giving this amazing opportunity to serve God exactly as I think He wants to be served. I mean, the efficiency, the effectiveness, the hope, the fact that you've constructed a system that where money coming in right now will flow into results that are demonstrable and immediately felt and experienced by patients now and into the future and not too distant future, and then longer into the far future. I mean, this is the time, and you have created this time. So we just want to thank you and emphasize that it's really because of this, because of your effectiveness and efficiency, that donations of any size are so effective. I mean, I was messaging with a donor this morning who's doing $25 a month. That's a surgery. Someone who gives $25 a month is giving a surgery, and a surgery in Tom's environment means that a woman who has a difficult birth and will otherwise die in childbirth or have devastating birth injuries now will go home shortly thereafter healthy. It means that a child who breaks his arm will have it repaired quickly. It means that a man who has a hernia will be back at work before he knows it. I mean, this, one surgery can transform someone's life, and that's $25 a month over the course of a year. And the BMONC centers, the birthing centers that we talked about, for $50,000 a year, that means that 20,000 moms and babies will be touched over a 5-year period. I mean, it's just staggering how far Jon and Tom, you enabled the dollar to go. So I just want to express my gratitude to you for enabling our dollars to go as far as humanly possible, or even inhumanly possible. You make it happen. So thank you.
All right. Thanks, Mark.
Thank you.
All right. So of course, anyone can follow up. Just go to the, of course, African Mission Healthcare website and, put in any questions or comments, and, someone will get right back to you. And we so deeply appreciate everyone's partnership. I mean, Tom has often said that, if it weren't for the donors, I'd be working with Band-Aids. And so we're all partners of Tom and of Jon, and it's a blessing of a lifetime to be your partner. So thank you.
So on behalf of African Mission Healthcare, we thank everyone for joining us today. To our panelists, to Mark, Tom, and Jon, thank you so much for all of the work that you do to make this work happen. And as you see in the chat, there are ways to support Dr. Tom and the efforts in Sudan. Feel free to partner with us as we meet our goal. Thank you again. And this recording will be sent to all participants today. Have a wonderful day, everyone.
Thank you, everyone.
Thanks, Janelle.